dear co-chair, ladies and gentlemen, thanks to scientific committee of this ESHO 2019 meeting, I have an opportunity to speak to you. The theme of my talk is brachytherapy in combination with interstitial hyperthermia. So due to lack of time, I will not talk about the old hyperthermia with brachytherapy studies. I will focus on Polish experience, because we are in Poland, and my own hobbies, which is prostate cancer. As we all know, hyperthermia is one of the most potent sensitizers for radiation therapy, and the thermal enhancement ratio was estimated to be about 1.4 to 2, and it has been suggested from in vitro studies that this effect is greatest when hyperthermia directly precedes radiotherapy. These effects were observed mainly in vitro studies, but we all, as a clinicians, want to prove that the same effects we can observe in our living patients, not on their cell lines. As you see, by increasing the time interval between hyperthermia and radiation, this synergy is lost. So when the patient moves from faraway hyperthermia center to, for example, chemo in the other center, he loses his time, thermal enhancement ratio, and probably also a lot of money. And the effects of hyperthermia are very complex, also on molecular level. The reoxygenation through increased blood flow and blood vessels permeability, induction of apoptosis, and the cell death in phase S, which is radioresistant phase of the cell cycle, and slowing down the repair process of radiation-induced DNA damage. But what is, I think, most important, the hyperthermia is too weak to cure the cancer by itself. It needs to be a part of combination therapy with chemo or radiation. On this slide we see how radiation therapy and hyperthermia complement one another. And the rationale for hyperthermia is, in first, that's my opinion, improvement of the response of tumors to radiotherapy by increasing the chance for local cure without increase of late toxicity. Or we can try to reduce radiation dose without decrease of effectiveness, but with reduction in toxicity, in late toxicity, which is toxicity which we don't like as radiation oncologists. Interstitial hyperthermia. Why interstitial hyperthermia and brachytherapy? The brachytherapy is an excellent method for providing stereotactic, ultraconformal, and very high radiation dose into the tumor or organ which contains cancer cells, with rapidly falling off those outside the target. Some brachytherapists say that it is iridium peak. Not so similar to Bragg peak for protons, for example. And interstitial hyperthermia, if it's delivered correctly, according to guidelines, of course, is a safe method for enhancement of radiation effects on cancer cells, of course without increase of toxicity. And here in Poland, we have the biggest cancer centers, 5 big cancer centers in 5 voivodeships in Poland are equipped with BSD 500 machines, which allow for superficial and interstitial treatments. In Warsaw, Gliwice, Kielce, Krakow, and Poznań. And let's see their experience. In Poznań, researchers with Professor Skowronek, who passed away last year, published in 2011 their preliminary work about thermal boost in breast brachytherapy. They treated 57 patients with breast cancer, stages 1A to 3A, with breast conserving surgery. After that was systemic treatment as indicated. It was chemotherapy or hormone therapy or both, standard external beam radiation for whole breast, or if indicated also lymph nodes. And brachytherapy boost 10 Gray in 1 fraction, 1 implant. 25 patients were treated without interstitial hyperthermia, and 32 patients with interstitial hyperthermia to 42 Celsius degrees for 60 minutes. This is how this treatment looked like. And median follow-up was 40 months in this article, and they observed no difference in early and late toxicity, and local control in both groups was 100%, unfortunately. Not fortunately, because this was the goal of the treatment, of course, but unfortunately for the study, because we cannot say no conclusions about that. Warsaw Center of Oncology, brachytherapy researchers conducted phase 3 randomized controlled trial. The patients with locally advanced cervical cancer, they received standard radiochemotherapy and brachytherapy as a boost, 4 times 7 Gray. 96 patients received also interstitial hyperthermia, and 109 patients were in control group. And there were also no differences in toxicity and 3-year disease-free survival and local control. But we must have this in mind that those are sometimes bulky disease in 3B or 4A patients. And when we are hitting only cervix, it's not possible to cover with adequate temperature and also in brachytherapy dose the periphery of sometimes very large tumors. And this is mainly my experience. In Krakow, we treated patients with prostate cancer with brachytherapy combined with interstitial hyperthermia. In salvage and also boost treatment after external beam radiation, we published our experience in 2 first publications in Strahlen Therapy and Oncology, and the last one updated those 2 publications in our Orange Journal. And the purpose, the aim of our retrospective studies, including my PhD thesis, was to evaluate the tolerance, early and late toxicities of AGR brachytherapy combined with interstitial hyperthermia in patients treated for prostate cancer. And during 5 years, we treated 105 patients with brachy plus hyperthermia. 76 patients were treated first with external beam radiation to prostate, seminal vesicles, and if the risk of spreading to lymph nodes was higher than 15%, also with regional nodes. And this was followed by HDR brachytherapy boost, and before delivery of radiation fraction was interstitial hyperthermia. It was performed interstitial hyperthermia. 3 patients who refused external beam radiation was treated with brachytherapy monotherapy, which consisted of 3 fractions by 15 Gray. And in 26 patients, we treated local recurrences of prostate cancer after previous definitive radiation therapy. This is how this treatment looks like. And our criteria, we used CTCAE version 4 for evaluating toxicities according to treatment, related to treatment. We extracted the data from International Prostate Symptom Score questionnaires and from patients' medical histories. The border between early and late complication was 6 months. The results in 26 median follow-up time was 26.4 months. And in patients who had follow-up time longer than 18 months, we evaluated also late toxicities and the treatment tolerance. Treatment in 98% of patients was at scheduled times. In one patient, due to grade 2 bleeding from rectum, we delayed by 1 week administration of the last treatment fraction. And one patient was, from the last fraction, disqualified by anesthesiologist. We didn't observe any grade 3 or higher toxicities related to treatment. And toxicities in grade 1 and 2 were common, as you can see on this table. But only 2 patients required temporary catheterization due to urethral stenosis. And we didn't see any significant differences in these early complications between the groups of patients treated with radical intent as a boost and monotherapy and salvage intent, except for hematuria and rectal bleeding. The late toxicities, as I said before, were evaluated only in 83 patients who had follow-up time at least 18 months. And here there were no statistically significant differences in late complications between the groups, radical and salvage. 2 patients, that's about 2.5%, developed late grade 3 urinary tract obstruction with urinary retention, and this required transurethral resection of the prostate. And in one patient it was 15, in second 22 months after completion of treatment. The incidence of grade 2 toxicity in these patients did not exceed 30%. And there were no late grade 2 or higher complications, only grade 1 complications from gastrointestinal tract. So in conclusion of these studies, we concluded that brachytherapy combined with interstitial hyperthermia in prostate cancer is well tolerated. The profile and the percentage of early complications is acceptable. And the risk of late grade 3 complications is minimal. And the rate of grade 2 symptoms does not exceed 17%. I said earlier 30%, but one of these is nocturia, which is only derived from IPSS questionnaires and isn't the CTC criterion. We also conducted the prospective study because we observed that after administration of hyperthermia in patients, the prostate is probably bigger. So we evaluated the changes of prostate volume and possible changes of brachytherapy treatment plan parameters due to interstitial hyperthermia, which was applied prior to high dose rate brachytherapy. And we compared these patients to our standard HDR brachytherapy procedure. We evaluated 60 consecutive patients with hyperthermia 30, without hyperthermia 30. And we performed a virtual plan before insertion of catheters, live plan after insertion of catheters, and post plan just before the removal of the catheters after delivery of brachytherapy. We compared prostate volumes, DVH parameters for PTV, rectum, and urethra, and we found that, of course, there are changes in prostate volume, but they are not statistically significant between these groups with hyperthermia or without hyperthermia. For patients without hyperthermia, this mean value of prostate volume increase is 5.47%, and for patients with hyperthermia it is 5.57%. So there is no actual difference. So does microwave interstitial hyperthermia prior to HDR brachytherapy change the prostate volume? The answer is no. And therefore it makes no sense to prepare another treatment plan for brachytherapy for patients with hyperthermia, which was suggested to my former chief. And the last topic of my presentation is our trial, which we developed with, the protocol was developed by me and Professor Wratislav Strnad from Erlangen. It's phase 2 study for patients for locally recurrent prostate carcinoma following external beam radiation therapy. This is the Atzelsberg circle where it all began. The idea of this trial was born in 2011 when I was first time at ESHO meeting in Aarhus. In Krakow, as I said, we had BSD 500 machine and used this in hyperthermia of prostate cancer patients, but we wanted to find researchers who do the same. We did this mainly because the National Health Fund in Poland pays for hyperthermia treatment when it's combined with radiation therapy. Unfortunately, during the ESHO 2011, we didn't hear any lectures about interstitial hyperthermia. So, but fortunately, there was presentation of Atzelsberger Kreis, the hyperthermia working group designing clinical trials, and we participated first time in that meeting in 2012, and thanks to Professor Rolf Sauer, who contacted us with Professor Strnad, we could develop the protocol of this study. And it was published in Polish Journal of Contemporary Brachytherapy in 2015. In March 2014, I started recruiting patients after receiving ethics committee approval to start the protocol. And at this moment, we have 3 study locations, Krakow and Warsaw in Poland, and Erlangen in Germany. The primary objective of this study is to estimate the rate of late grade 3 or higher complications related to salvage treatment proposed by protocol. And the target volume is prostate and any extracapsular or seminal vesicle extension, which we can in which we can put needles. Brachytherapy dose is specified on tumor margin, and there are 2 brachytherapy methods permitted. HDR is preferred in Poland, and PDR preferred by Erlangen. And interstitial hyperthermia of the prostate to the temperature range of 47 Celsius degrees should be scheduled before every brachytherapy fraction. The therapeutic time is 60 minutes. Hyperthermia will be delivered in accordance with RTOG quality guidelines for interstitial hyperthermia. Those are old guidelines. New are from this year, and the next study probably will be with new guidelines. The main inclusion criteria is locally recurrent prostate cancer, confirmed histologically or by biopsy or PSMA PET, without metastasis to lymph nodes or organs. As I said, the ethics committee approval was received in February 2014, and now we have 94 patients recruited of 77 planned, but Professor Strnad told that we should break the barrier of 100 patients because it's a psychological barrier for publications, so we will reach this, I think, in 1 or 2 months. So I would like to invite you to my lovely Roztocze region, which is quiet and beautiful. Thank you for your attention.
Thank you very much. I think the combination of interstitial radiotherapy and interstitial hyperthermia in prostate cancer is very interesting. Unfortunately, the interstitial trial of hyperthermia in cervical cancer was not successful. Do you know some reasons? You said that this is a large tumor volume. What was the local recurrence rate?
Those are failure. These failures, local failures, were mainly due not to recurrence, but not to local cure.
Yes. Further questions? The next step must be, I think, an randomized study of interstitial brachytherapy and versus the same plus hyperthermia in prostate, salvage prostate cancer. From the clinical experience I have in Erlangen, I see most of the patients, or some of the patients, it works very well.
Erlangen also in clinical trials .gov, there's registered another trial in Erlangen for recurrent head and neck cancers. So interstitial hyperthermia, I think, has a big potential, but and we have now new quality assurance guidelines. So I think it is very good method, and it could be broader used. If we have in Poland 5 machines, I thought we will recruit patients very fast, but the problem with prostate was that we should use catheters which we cannot sorry for my English. Which we can use only one time, and for 3 fractions it is not cost-effective treatment.